Welcome to the deep dive. The human mind, it's just incredibly complex, isn't it? An amazing system. But sometimes that complexity, well, it can lead to conditions that really change how people experience the world, their thoughts, their everyday lives. Today, we're doing a deep dive into the really fascinating and sometimes quite challenging world of psychiatric and neurocognitive disorders. We've gathered insights from some pretty comprehensive sources. We're looking at everything from the schizophrenia spectrum to Alzheimer's and even mental health in kids and teens. Our mission here is to kind of sift through all that information, pull out the key insights, the important stuff, and give you a clearer picture of these conditions, what we know about causes, how they're addressed. Basically a shortcut to getting well informed, maybe with a few surprising things along the way. So let's just jump right in. Okay, so schizophrenia spectrum disorders, that sounds broader than just one thing. What exactly are we talking about here?
You're spot on. It's
Yeah.
not just one single diagnosis. These are what we classify as primary psychotic disorders, meaning they really fundamentally affect how a person thinks, feels, and behaves. When we look at the core symptoms, we're talking about abnormalities in really 5 key areas. There are delusions, those fixed false beliefs.
Right, despite evidence against them.
Exactly.
Mhm.
Then hallucinations, seeing or hearing things that aren't there. Disorganized thoughts where speech can get really jumbled or off topic. Also disorganized or abnormal motor behavior. And then there's the 5th category, negative symptoms.
Okay, negative symptoms. That doesn't sound like, bad symptoms necessarily, but something different. Can you unpack that?
Precisely. It's a common point of confusion. Negative here doesn't mean bad. It means a loss or a lack of normal functions. Think of it like less emotional expression, maybe reduced motivation or speech, difficulty feeling pleasure. They can be really, really disabling. And it's worth mentioning, too, while we're focusing on primary psychotic disorders, you can see secondary psychotic symptoms with other neurological issues as well.
That's a really important distinction. Thanks. And, speaking of how common this is, something from our sources jumped out at me. The lifetime prevalence of schizophrenia is 1% worldwide. That feels
Sure.
surprisingly high.
It is a significant number, absolutely. 1% translates to millions of people globally.
Does it matter when symptoms start? Does the age of onset change things for someone?
Oh, absolutely.
Yeah.
The age of onset is a huge factor in the prognosis. If symptoms show up early, say in adolescence or early adulthood, well, there's often more evidence of structural brain abnormalities. These individuals tend to have more prominent negative symptoms, more disabling symptoms, and sadly, often a poorer long-term outlook.
Okay. And if it starts later?
If the onset is later, maybe between 25 and 35, those individuals are statistically more likely to be female. They often show less evidence of those structural brain changes. And generally speaking, they tend to have better long-term outcomes. So it really highlights the diversity within this spectrum.
So clearly not a simple cause and effect thing. What are the underlying factors? Are we
Yeah.
still thinking of it as just one disease?
That's where it gets really fascinating. And the thinking has evolved. It's incredibly complex. The risk factors involve changes in brain structure, disruptions in neurotransmitter systems like dopamine, serotonin, glutamate, NMDA receptors,
Mm-hmm.
and alterations to neural circuits.
Yeah.
And all of this is influenced by both genetic and non-genetic factors.
Yeah.
Genetically, studies of families, siblings, twins, they've given us huge insights. And some research is even suggesting there might be, get this, a group of 8 genetically different types of schizophrenias.
8 different types. Wow.
Yeah, and that maybe 42 different genes work together to create specific symptom profiles. It's moving towards a much more nuanced view.
So the big takeaway then is schizophrenia isn't one single illness, but maybe more like a collection of related conditions, each with its own kind of genetic signature. What could that mean down the line?
Exactly. It suggests schizophrenia might be an umbrella term for biologically distinct subtypes. And that, opens the door for more personalized targeted treatments eventually, rather than a one-size-fits-all approach.
Right.
There's also this concept of synaptic pruning, that normal process where the brain gets rid of unused connections during adolescence.
Right, fine-tuning the brain.
Yes. Well, a disruption in that critical developmental stage might play a pretty significant role in symptoms, starting for some people. And supporting this idea of it being a brain disease, neuroanatomical studies show evidence of a neurodegenerative component after onset. We see decreased brain tissue and volume, larger ventricles, those fluid-filled spaces, some frontal lobe atrophy, more cerebrospinal fluid overall.
Right.
Beyond the brain structure and genes, there are non-genetic risks too. The neurodevelopmental vulnerability model points to things like prenatal or perinatal issues, the role of the immune system, and definitely the impact of social, psychological, and physical stress.
That brings up a really important point. How does culture fit into this? Does the experience or even the understanding of these symptoms change depending on where you are in the world?
That's an excellent question, and it really grounds the science in human experience. While the basic developmental pattern of symptoms seems pretty consistent across cultures, the interpretation can vary wildly, especially for things like hallucinations. In, say, industrialized nations, they're often seen strictly as a symptom of illness.
Right.
But in some developing countries, those same experiences might be interpreted very differently, maybe as spiritual messages or supernatural events. Cultures also differ a lot in how they attribute mental illness itself. Some lean towards religious or spiritual explanations, others more biomedical. And that difference massively impacts how people seek help, or even if they accept it. Cultural competence is just vital.
That makes total sense. So let's talk about the illness journey itself. It's not static, is it? It seems to move through phases. And Mean's story from our sources really illustrates this.
Yeah, Mean was described as quiet. Then around 17, she started isolating herself, just listening to music for hours, missing school, saying her future was in music, even though she didn't play an instrument. This sounds like that prodromal phase you mentioned, those early warning signs.
Exactly. That withdrawal, the unusual preoccupation, those are classic signs of the prodromal phase, the period before the illness fully manifests. And unfortunately, that phase can escalate. Which brings us to the acute phase. This is where you see those well-developed symptoms, the positive, negative, cognitive, and mood symptoms we talked about.
Right. And for Mean,
Mm.
it got intense quickly. It really did. Within 3 weeks, she wasn't going to school at all, only talking about music. Her parents, struggling with English, were understandably lost. She ended up in the emergency department, hadn't showered, refused food thinking it was poisoned, just sitting in a dark room with music blasting. The psychiatrist observed her, admitted her. That's a stark picture of the acute phase.
Such a difficult situation. After that acute crisis, what's the typical progression?
Well, following the acute phase, the goal is to enter the stabilization phase. This is where those acute symptoms, especially the positive ones like hallucinations or delusions, start to decrease in severity. We're trying to get things under control. And then ideally comes the maintenance phase. Symptoms are in remission here, though sometimes milder, persistent, kind of residual symptoms might linger. Mean's story, though, it really underscores the long-term impact. 3 years later, diagnosed, multiple acute phases, living with her parents on limited income, applying for Medicaid. It just shows how profoundly a diagnosis like this alters a life, a family, and highlights that critical need for ongoing support and resources. Healthcare professionals play a huge role in helping people cope.
Beyond schizophrenia itself, the sources mentioned other related psychotic disorders briefly. Just for context, what are a few of those?
Right. It's helpful to know the spectrum is broad. For instance, schizophreniform disorder, basically identical symptoms to schizophrenia, but shorter duration, less than 6 months. Brief psychotic disorder is characterized by a very sudden onset, often after major stress. Schizoaffective disorder is interesting. It mixes schizophrenia symptoms with a major mood disorder, like depression or bipolar. Makes diagnosis tricky.
Okay.
Then there's delusional disorder, which mainly involves delusions, often ones that could be true, but aren't without all the other psychotic symptoms. And finally, substance medication-induced psychotic disorder, which, like the name says, is directly caused by substance use or withdrawal. Just shows how varied psychosis can be.
Okay, shifting gears a bit. Our sources also talk about challenges with how our brains process information, these neurocognitive challenges. What exactly do we mean by cognition here? What are its building blocks?
That's a great transition because cognition is so fundamental. Broadly, it's the mental process of, acquiring knowledge and understanding through thought, experience, the senses. It's all the processes involved in human thought. And it impacts everything: physical, psychological, social life. Our sources break it down into 6 key cognitive domains: complex attention, executive functioning.
Like planning and decision-making.
Exactly. Then learning and memory, language, perceptual motor abilities, and social cognition, understanding social cues. These are the functions that get disrupted in neurocognitive disorders.
Okay, let's start with delirium. That sounds like a really sudden, serious shift in those functions. What makes delirium stand out?
Delirium is distinct primarily because of its speed. It's characterized by rapid disturbances in attention and awareness, sudden loss of focus, real confusion, and cognitive disturbances too: thinking, memory, orientation issues. A key feature is that symptoms develop quickly, often fluctuating through the day. You might hear about sundown syndrome, confusion worsening in the evening.
Yes.
And maybe the most crucial point, delirium always develops as a direct result of an underlying medical condition. An infection, a medication reaction, metabolic imbalance, something physical.
So, unlike many conditions we discussed, delirium is almost always tied directly to a physical cause. Identifying and treating that cause is paramount then. How common is it, and what does it actually look like?
It's surprisingly common, especially in vulnerable groups. Post-surgical older adults, 53%. Nursing home residents over 75, up to 60%. Intensive care patients, maybe 87%. Really high rates. There are different types: hyperactive, hypoactive, mixed. Signs can include cognitive issues like illusions or hallucinations, often visual or tactile. Physically, maybe wandering, falls, disrupted sleep, being hypervigilant. Moods can swing wildly too. So the absolute number one priority in care is patient safety. Never leave someone in acute delirium alone. Trained sitters using engagement techniques are key.
And the treatment.
Well, primarily, find and treat that an underlying medical cause. Beyond that, it's about supportive care. Continual reorientation, managing sensory input, controlling pain, getting them moving early if possible, maintaining oxygen, hydration, nutrition, promoting sleep, all crucial. If someone gets combative, you acknowledge their distress but ignore insults, focus on de-escalation.
Okay, moving to another major neurocognitive challenge, Alzheimer's disease. How is this different from delirium, and what are the big risk factors?
Alzheimer's disease, or AD, is a major neurocognitive disorder, what people often just call dementia. The key difference from delirium is the onset. AD usually develops much more slowly. It's a progressive decline, not that sudden shift we see in delirium. And it's the most common cause of dementia. Risk factors. Age is the biggest one. Incidence doubles after 65. Gender plays a role. About 2/3 of diagnoses are in women. Family history increases risk, though it's definitely not required to develop it.
And what's actually happening inside the brain with Alzheimer's? What are those changes?
Pathologically, it's pretty dramatic. You get the buildup of amyloid plaques, these sticky protein clumps between nerve cells,
Yeah.
and the neurofibrillary tangles, twisted protein fibers inside the cells.
Okay, so gunk building up both inside and outside the cells?
Kind of, yeah. Both disrupt cell function, leading to synapses deteriorating and eventually nerve cells dying off. Anatomically, this results in cortical atrophy. The brain tissue itself shrinks, especially in areas for higher functions like memory and thinking. The hippocampus, crucial for memory, gets damaged. And those ventricles, the fluid spaces, they get larger as brain tissue is lost.
So the brain is literally shrinking in key areas. It sounds like the tissue itself is wasting away.
That's a good way to put it. Like, parts of a complex network are fraying and disconnecting. That's why we see the characteristic symptoms. People with AD often show what are called the four defense behaviors. There's denial, trying to cover up memory loss; confabulation, making up answers to sort of maintain self-esteem when they don't know; perseveration, repeating phrases or actions; and avoidance of questions.
And the cognitive symptoms, you mentioned the 4A's.
Right, the four A's are common markers of cognitive impairment: amnesia, memory loss; aphasia, language difficulties; apraxia, trouble with motor tasks; and agnosia, difficulty recognizing objects or people. And the disease typically progresses through stages mild, moderate to severe, and late stage.
So what does this all mean for the families who are trying to navigate this diagnosis? And do cultural factors influence how people cope or seek help?
That's hugely important. While the core symptoms look similar across cultures, our sources do point out differences in incidence rates between ethnic and racial groups. These seem mostly linked to variations in health, lifestyle, socioeconomic factors, rather than purely genetics. But maybe even more critical is how acceptance of an AD diagnosis varies culturally.
Stigma or different beliefs.
Exactly. Stigma, different understandings of aging or cognitive decline, it can really affect how families respond, whether they seek support, how they provide care. Common challenges for everyone involved include risk for injury, communication problems, confusion, memory issues, coping difficulties for the person, and of course, significant caregiver stress. Understanding those cultural nuances is key for providing truly supportive care.
Okay, let's transition now. We need to talk about mental health across the whole lifespan, especially the unique challenges for children and adolescents. What makes this group different, and why is it such a critical area?
It's incredibly critical, primarily because for many psychiatric disorders, the very first symptoms appear in early childhood or early adolescence. That's when things often start. The prevalence numbers are sobering. Our sources suggest up to 21% of kids aged 9 to 21 experience a psychiatric disorder, but tragically, maybe only about a fifth of those who need help actually receive it.
Only a fifth? That's concerning.
It really is. And what makes it more complex is that kids often meet criteria for more than one diagnosis simultaneously. Plus, you're dealing with a developing brain, unique social pressures. It's not just miniature adult psychiatry. You need a totally different lens.
Given that developmental context, how does assessing mental health in kids and teens differ from adults? What are you looking for?
The assessment has to be much more focused on developmental stages. It's really holistic. You look at the presenting problem, sure, but also their medical history, developmental milestones, family history, a physical exam, and importantly, their adverse childhood experiences, or ACE score, that helps understand potential trauma. A mental status exam is key too. For adolescents, you also need to specifically ask about things like substance use, sexual activity, self-harm, suicidal thoughts, as these risks increase.
Let's touch on some specific neurodevelopmental disorders. What about intellectual disability, or ID? What defines it, and what are some causes and interventions?
Intellectual disability, ID, involves significant limits in both intellectual functioning, reasoning, problem-solving, and adaptive behavior, which covers practical social skills. Severity ranges from mild to profound. Causes are really varied. Some are hereditary, like Tay-Sachs or Fragile X syndrome. Some stem from issues in early embryonic development, Down syndrome, fetal alcohol syndrome. Problems during pregnancy or birth, like malnutrition, prematurity, lack of oxygen, infections, can play a role. Later trauma or poisoning, too.
How is it diagnosed?
Well, sometimes in severe cases, there are physical clues. But often it starts with screenings during regular checkups. Developmental delays trigger referrals. Then you might use blood tests, DNA testing, brain scans, IQ tests, and looking at whether they're meeting those key developmental milestones. Interventions are comprehensive. Individual and family counseling, making sure they get appropriate schooling, often involving an individualized educational plan or IEP.
Right, tailored school support.
Exactly. Occupational therapy, behavioral therapies, and sometimes medication, usually for co-occurring conditions like anxiety or ADHD.
What about communication issues, like stuttering or autism spectrum disorders? How are those identified and helped?
Communication disorders cover things like language disorders, speech sound disorders, childhood onset fluency disorder, which is stuttering, and social communication disorder. If delays are noted, kids usually get referred to a speech therapist or school psychologist. Therapy focuses on building those skills, often with supportive counseling. Now, autism spectrum disorders, ASDs. The key features are deficits in social communication and interaction, and also restricted, repetitive patterns of behavior, interests, or activities.
Okay.
Assessment involves looking for those social deficits, maybe difficulty bonding with parents, not liking cuddling, poor eye contact, lack of peer interaction. Communication delays are common, as are rigid routines or intense focus interests. Diagnosis usually happens between ages 2 and 3, often by specialists like child psychiatrists or developmental pediatricians. And this is critical. Early diagnosis and early intervention are strongly linked with better outcomes.
So getting help early makes a real difference. What does that help look like?
It's a real team effort. You'll often have a speech therapist for language, an occupational therapist for sensory issues or managing repetitive behaviors, a physical therapist for coordination. A psychiatric provider, like a nurse practitioner or a child psychiatrist, might manage medication if needed for associated symptoms. And school support is huge: tutoring, smaller classes, different teaching methods.
And ADHD, attention deficit hyperactivity disorder, another common one. How does that usually show up, and what's the approach there?
ADHD typically involves problems with concentration, careless mistakes, trouble staying focused, being easily distracted. Kids might avoid tasks needing sustained effort, lose things, be disorganized. The hyperactivity impulsivity part can look like fidgeting, running, or climbing when inappropriate, interrupting, talking excessively. In adults, it might be more of an internal restlessness.
How is it diagnosed and treated?
Nurses or teachers often notice at first the fidgeting, difficulty paying attention, impulsivity. Schools might recommend evaluation. Vanderbilt assessment scales are commonly used questionnaires. Primary care doctors can often diagnose straightforward cases, but if things are complex or don't improve, referral to a psychiatric specialist is common. Interventions usually involve a mix: behavior modification therapy, parent training, school accommodations, and medication to help with focus and hyperactivity.
This really shows the sheer breadth of challenges young people can face. Beyond these specific neurodevelopmental disorders, what other mental health issues are common in youth that might surprise people? What's the common thread in helping them?
Well, there's quite a range. You see specific learning disorders like dyslexia or dyscalculia, difficulties with reading, writing, math, usually showing up in elementary school.
Hmm.
Addressed with testing and accommodations like tutoring, motor disorders like developmental coordination disorder, clumsiness, or Tourette's disorder with its tics. These are often managed with behavioral therapy, sometimes meds. Mood disorders in kids can be controversial to diagnose, but disruptive mood dysregulation disorder, DMDD, involves severe, persistent irritability and outbursts. Suicide risk assessment is critical here. Anxiety disorders are very common: separation anxiety, phobias. Therapy like CBT, family therapy, sometimes medication helps. Obsessive-compulsive and related disorders, like hair pulling, often respond well to CBT. Trauma and stressor-related disorders, like reactive attachment disorder from inconsistent caregiving, really highlight the need for family-focused therapy. Even feeding and eating disorders or elimination disorders like bedwetting need specific behavioral approaches. The common thread, it's almost always a holistic, patient-centered approach. Early identification, getting parents involved, and using a multidisciplinary team are key across the board.
That's a great point about teamwork. Care plans for kids and teens really do emphasize involving parents and using a whole toolbox of therapies: CBT, group therapy, play therapy, art, music, recreation. It's very person-centered. And it's noted that restraints or seclusion are truly last resorts, only for immediate danger, with things like quiet rooms preferred.
Absolutely. And that interprofessional collaboration is essential.
Mm.
Speech therapists, OTs, PTs, school psychologists, child psychiatrists, pediatricians, nurses, everyone working together is crucial for meeting these complex needs.
So, with all these different conditions and needs across ages, what are the essential tools clinicians use? Let's look at the general toolkit for care interventions and the path to recovery for everyone. Are there universal assessment guidelines?
Yes, there are some crucial guidelines that apply pretty much across the board for psychotic and neurocognitive disorders. First, you always have to rule out a medical cause or substance use mimicking the symptoms. That's step one. It's vital to assess for command hallucinations, voices telling someone to do harmful things. You need to understand their belief system, check for other co-occurring conditions, review all their medications, and critically, you need to understand how the family is responding and what support systems are actually in place.
Communication sounds absolutely key, especially if someone is experiencing hallucinations or delusions. What are some effective strategies?
Definitely key. If someone seems to be responding to internal stimuli, like voices, you adjust. Maybe wait a bit longer for them to respond, repeat questions gently, use shorter, simpler sentences. For hallucinations specifically, watch for cues they might be experiencing them. Ask directly. Crucially, find out if the voices are telling them to harm anyone that triggers a duty to warn and means close observation. You accept the voices are real to them, but state calmly that you don't hear them. Keep the environment calm, focus on reality-based topics, help identify triggers.
And for delusions, you can't just argue someone out of a firmly held false belief, right?
Exactly. Arguing is pointless and often counterproductive. Remember, the delusion is their reality at that moment. Instead, gently engage them in reality-based activities, maybe simple yoga, going for a walk. If dealing with paranoia, try positioning yourself beside them, not face-to-face. Less direct eye contact. Use a calm, matter-of-fact tone. Offer food in closed containers if they're suspicious. Stick to non-competitive activities. Watch for triggers.
And if someone's thoughts seem really disorganized, that associative looseness.
Don't pretend you understand if you don't. It's okay to say, "I'm having trouble following that," or gently try to verbalize what you think they mean. Focus on the here and now, the immediate environment, and gently reinforce clear communication when it happens.
So, milieu therapy, creating that therapeutic environment, how does that fit in?
Milieu therapy is all about the setting itself being therapeutic. It provides emotional and physical safety, offers useful activities, helps with conflict resolution, gives chances to practice social or vocational skills. In acute phases, safety is paramount, so it includes things like verbal de-escalation, maybe sedatives if needed, and using restraints or seclusion only as an absolute last resort to prevent harm.
And health teaching, psychoeducation for the patient and family, what's the main goal there?
The goal is empowerment, really. To provide information that supports their recovery journey, helps them manage symptoms better, instills hope, promotes overall wellness, and boosts self-esteem. It gives them tools.
Okay, let's talk about the medications, the pharmacology. This is a huge part of the toolkit for many. What's the big picture difference between the older first-generation antipsychotics and the newer second-generation ones. What does that mean practically for someone taking them?
That's a really important distinction. Think of the first-generation antipsychotics, FGAs, or neuroleptics.
Yeah.
They're kind of like older, strong tools. They mainly block dopamine D2 receptors, very effective for positive symptoms like hallucinations, delusions. But they carry a higher risk of extrapyramidal symptoms, EPS. Those are movement side effects, stiffness, tremors, restlessness, sometimes long-term issues like tardive dyskinesia,
Mm.
plus other side effects like sedation, dry mouth, and the rare but serious neuroleptic malignant syndrome, NMS. Haloperidol is a common example.
Okay, so effective, but potentially more movement
Yeah.
side effects. And the second generation.
The second generation SGAs, or atypicals, are generally more refined. They work on both serotonin and dopamine receptors, often with less intense dopamine blockade. The main advantage: generally fewer EPS side effects, which is huge for tolerability. However, they come with their own baggage, particularly metabolic side effects. Significant weight gain, increased risk of diabetes, high cholesterol. These need careful monitoring.
So different side effect profiles. Any key examples of SGAs?
Sure, clozapine is highly effective, maybe the most effective, but has that risk of a granulocytosis, needing regular blood tests. Olanzapine is also very effective, but known for significant weight gain. Risperidone works well, can cause EPS at higher doses, available as a long-acting injection, which helps with adherence. Quecapine is often used for sedation and mood because it hits histamine receptors hard. Aripiprazole is interesting, a dopamine serotonin stabilizer, can help positive symptoms, but also depression, anxiety. There are many others, like ziprasidone, lurasidone, cariprazine, each with slightly different profiles. It's about finding the best fit, balancing efficacy and side effects for the individual.
That's an incredibly helpful breakdown. It all points to such complex brain chemistry. How does something like psychoneuroimmunology, PNI, fit into this picture? It sounds like connecting different systems.
It really is connecting the dots in a fascinating way. PNI looks at the interaction between the immune system and the nervous system. It kind of breaks down that old mind-body separation. The idea is that, say, chronic inflammation releases these chemicals, cytokines, which can actually change brain plasticity, that maybe reduce the growth of new neurons in areas like the hippocampus.
Wow. So inflammation could affect learning and mood?
Potentially, yes. It suggests pathways where immune responses could contribute to conditions like depression, or maybe even aspects of schizophrenia. It opens up whole new ways of thinking about causes and treatments, looking beyond just neurotransmitters.
Fascinating. Now, beyond meds, what psychosocial therapies are really crucial for recovery?
Medication is often essential, but psychosocial therapies are just as critical. The program of assertive community treatment, ACT, is huge. It's intensive outreach for people who struggle most, helping them stay stable in the community, preventing relapse. Family psychoeducation and therapy are vital too. Engaging families as partners, teaching them specific coping skills, often done in groups. Cognitive behavioral therapy, CBT, especially recovery-focused CBT, helps people challenge those self-defeating thoughts and beliefs.
And these aren't just talk therapy, right? They involve practical skills.
Absolutely. Cognitive remediation uses exercises, almost like brain training, to improve memory, attention, executive function. Social skills training directly teaches interaction skills, illness management, how to participate more fully in life and work. All of these really fit under the umbrella of the recovery model and recovery-oriented care. The focus shifts to the person's strengths, their goals, achieving the best possible quality of life. Recovery is seen as a personal journey of change.
That sounds much more hopeful and person-driven. Is there evidence this approach works?
Yes, definitely. The RAISE project, that NIMH study from 2008, showed really positive results. People in recovery-oriented early intervention programs stayed in treatment longer, had better symptom improvement, better relationships, better quality of life. The challenge now is getting this evidence-based approach implemented more widely in communities.
So for someone experiencing these conditions, the message is really about building a path forward, focusing on strengths and sustained progress. If people want more information or support, where should they look?
There are some excellent resources. The National Alliance on Mental Illness, or NAMI, is fantastic. The National Institute of Mental Health, NIMH, has great info. Mental Health America, mentalhealth.net. For schizophrenia specifically, schizophrenia.com and SARTA are good. Janssen Canada also has resources, lots of places to get reliable information and find support networks.
When evaluating how care is going, what's important for everyone, clinicians, patients, families, to keep in mind?
Setting realistic outcomes together is key. Goals that the clinician and patient both agree on are more likely to succeed. And maybe most importantly, everyone needs to remember that change takes time. Especially with something like schizophrenia or progressive neurocognitive disorder, progress might be slow, sometimes with setbacks. Patience, persistence, celebrating small steps, that's really crucial.
We have covered so much ground today, a truly complex, vital area, psychiatric and neurocognitive disorders. We've touched on the biology of schizophrenia, the unique needs of children, the progression of Alzheimer's. We've seen how science is digging deeper into the brain's complexities, and how care is thankfully moving towards being more holistic, more recovery focused. So, as we wrap up this deep dive, here's something to think about. Knowing how vast these conditions are, but also seeing the progress in understanding and treatment. How can we all, as individuals, as a society, really foster environments filled with more empathy, better understanding, and truly robust support? What's one thing from our conversation today that stands out to you, something you'll carry forward? Maybe it challenges an old idea or gives you a new perspective on mental health as just fundamental human health.